Welcome to the Trinity Health IHA Medical Group Wednesday Wellness Series. This webinar is titled Understanding Pediatric Vaccines, a live conversation with physicians caring for pediatric patients, and is presented as a collaboration between providers from Trinity Health IHA Medical Group in Southeast Michigan and Trinity Health Medical Group in West Michigan. Presenting providers tonight are Pediatricians Melissa Heinen, who sees patients in Plymouth, and Jennifer McDonald, who sees patients in Canton, Ypsilanti.
Yes.
Yeah, so Jennifer McDonald, who sees patients in Ypsilanti, and internal medicine and pediatrics physician Andre Hollingsworth, who sees patients in Byron Center. Welcome.
Thank you, Nelson. Thank you for having us. We're excited to be here in a very exciting time to talk about everyone's favorite topic, pediatric vaccines. So welcome, everybody.
All right, so I'll start out. Thank you, Dr. Heinen. So I think I speak for my colleagues here on the call when I say that being a pediatrician is such a privilege. It's such a privilege to get welcomed into people's families' lives and for parents to come to us and allow us to help them keep their kids healthy. And so, as a doctor, we're trained to diagnose and treat disease. That's a big part of what we do. We also, a big part of what we do, especially in pediatrics, is prevention, so keeping kids healthy. And we really act as risk advisors for families. So you've probably had us talk to you about prevention of sudden unexplained infant death, for example, recommending safe sleep practices, that babies should sleep on their backs with nothing else in their crib. We've probably talked about the risk of head injury when kids are riding their bikes or their scooters. And so we talk about helmet use. And in that same kind of bucket of tools we have to tell you about risk and then give you something to do about the risk of illness or injury, we have vaccines. And that's probably the thing that we have in pediatrics, me as an individual pediatrics, but also pediatrics as a field. It is the tool that we have that prevents the most illness and saves the most lives. And so to just illustrate that, there have been studies that have really tried to put numbers on this, but we know that there was a study that came out in, the MMWR is something that the CDC publishes, and they looked at a group of children born between 1994 and 2023, or the cohort of kids born in that time, and they estimated that vaccines prevented over 500 million illnesses and saved more than 1 million lives. And I'm so grateful that I have vaccines like in my toolkit of things that I can discuss and offer to families to keep their kids safe. And so if you can go to the next slide for me. So we had the other thing I wanted to do is thank the people who had submitted questions. So great. And thank you for coming and having interest in this topic. And one of the questions, what we tried to do is take your questions, and we kind of built the slides around your questions. So I'm hoping that most of you will see your questions reflected in the slides that we've made. But of course, if we didn't get to your question or you have new questions, please put them in the Q&A, as we said. But one of the questions that came up is kind of like, what is going on with vaccines? So I think it makes sense to have a slide where we kind of talk about the elephant in the room, which is that recently vaccines have been in the news a lot. And I think it's been really confusing for parents. I think there's been aspects of it that have been confusing for providers. And so I wanted to talk about that a little bit, what has changed. So to understand what has changed, I want to talk a little bit about how things have typically worked with creation of the childhood immunization schedule. So historically, what we have is the FDA licensed vaccines. We're going to talk later about how vaccines are tested for safety, but a lot of that happens before they get licensed by the Food and Drug Administration. And then once a vaccine is licensed, so they've said that it's safe for certain age groups and it protects against certain disease, then it's really the job of the Advisory Committee on Immunization Practices, or the ACIP, which is a committee that advises the CDC, which is the Centers for Disease Control and Prevention, about what should be on the childhood immunization schedule. And historically, that group of people that were the ACIP members, they were experts, deep expertise in pediatrics, public health, infectious disease, vaccine science. And they would use something called the evidence to recommendation framework. And what that means is that for a given question, like let's say they're deciding whether or not the RSV vaccine, which is a relatively new vaccine that was added to the schedule, whether or not it should be added. They look at all of the papers that have been published on that topic and they grade them. They give them like different grades based on the strength of the paper, its strengths, its weaknesses. And then they look at all of that together and they use all of the evidence, the graded evidence, to make a decision about the immunization schedule. So that's kind of the old way. As of June of this year, the new administration, the leadership at the Department of Health and Human Services, fired all of the members. There were 17 members of the ACIP, and created new membership, so appointed new members to the ACIP. And the new members, it's been reported widely in the news, they don't have the same expertise as prior ACIPs. And even if that alone weren't concerning, the thing that's really concerning the medical community is that they aren't using that evidence to recommendation framework. And that's something that's been really undermined the credibility of the ACIP. So what has changed is that the American Academy of Pediatrics in August, that's the professional group for pediatricians, actually committed to publishing a vaccine schedule that continues to use the evidence to recommendation framework. And so we now have a CDC generated childhood immunization schedule, and we have the AAP generated schedule. They're actually right now fairly similar. The main difference, which we will look at later, is that recommendations surrounding a COVID vaccine. But I think the AAP felt that we needed to come up with this additional ability to make a schedule based on this evidence to recommendation framework, because of what's been going on at the ACIP just hasn't looked like what it's looked like in the past. So that's what's new. But what has not changed is that we're still talking about the same safe and effective vaccines. Like I said, the two schedules really haven't diverged very much at this point. The COVID vaccine recommendation is the main difference between the two schedules. And the other thing that hasn't changed is that as a field, as pediatricians, we are here to use the best available science to keep your kids safe and healthy and to make recommendations to you about what risks exist and how you can minimize those risks. All right, I'm going to go to the next slide. So here is, this is the current AAP schedule for kids through 6 years of age. Again, this was published in August, and there's a link here, and these slides will go out to you so you're able to link and go to this schedule. I always like to share with my patients that I actually had my kids before I was a pediatrician, before I went to medical school. And I remember taking my newborn to the doctor and seeing the schedule and being like, that is a lot of stuff. And so I empathize with parents, and I understand why when you see this schedule, you might initially pause. It looks like a lot. In the end, I had a great pediatrician for both my kids, and they, walked me through why it was important for my kids to get their vaccines, and both my children are fully immunized. And then I went through training, all this training, and I saw, I trained in preventive medicine, which is a public health specialty, and then I trained in pediatrics. And through my training, I saw children sick with illnesses that can be prevented with vaccines. And I've even seen children die of illnesses that can be prevented by vaccines. And so now with my, those were my mom goggles that I had on in the past, but now with my mom and my doctor glasses on, and I look at the schedule, I just am thrilled that I have the ability to offer protection against all these illnesses to the families that I see. So let me walk through this a little bit, because there's a lot of there's a lot of different abbreviations. So again, this is for children through 6 years of age. Some of the questions, this slide actually addresses several of the questions that came up. So I'm going to go into those in just a second, but let me tell you what these different things stand for. So I'm going to start at the top. RSV is respiratory syncytial virus. Second one is hepatitis B. RV is rotavirus, which is a diarrheal illness or a virus that causes a diarrheal illness. There's diphtheria, tetanus, pertussis. Haemophilus influenza is HIB. PCV is pneumococcal conjugate vaccine. IPV is the polio vaccine. We all are familiar with COVID-19, influenza. MMR stands for measles, mumps, rubella. Varicella is chickenpox, and then hepatitis A. And so one of the questions that was submitted was, what is recommended at birth? And so here you can see that at birth, it's recommended that all babies get a hepatitis B vaccine. Later on in the presentation, Dr. Heinen is going to talk a little bit more about hepatitis B vaccine because that's also been in the news because of the recent ACIP meeting. But hepatitis B vaccine is recommended at birth. And then the other one that's recommended at birth is a respiratory syncytial virus vaccine. If the mother hasn't had a vaccine during the pregnancy, it's recommended that babies get that if it's during RSV season, which runs from October to March. So that was one specific question I wanted to address. Another question that came up several times was, why are there so many in the first 24 months of life? And you can see that this schedule is very kind of front loaded. And then we're going to go on this next slide. It will go to up through age 18, and you'll see there's a lot fewer vaccines. And the reason for that is because for these illnesses that science has developed, they've been able to develop vaccines. These are illnesses that tend to impact youngest children worse than older children. So it's essential to get that protection in early. And then the other thing that people notice is that you don't just get one DTaP. On this, you can see that you're getting, 4 doses across the first 6 years of life of, for example, the diphtheria, tetanus, pertussis vaccine. Why is that? Well, the reason is that the young immune system is relatively immature. And so you have to give the dose to start the process of the body building immunity to these different illnesses. And then you boost those doses so that every time you give another vaccine, you're kind of boosting the body's ability to recognize and then fight that infection in case the child were exposed to that infection. I'm trying to think if any of the other questions applied to this slide. One other thing I want to say is it looks like a lot, and it is a lot, but let's just break it down because we have some tools in our toolbox that make it not so many injections. So I'd like to just focus in on the 2-month visit. So at the 2-month visit, let's assume that a baby has already had their RSV vaccine and their hepatitis B. At 2 months, they will get a second hepatitis B. They'll get a rotavirus vaccine. They're due for diphtheria, tetanus, pertussis, Haemophilus influenza, pneumococcal conjugate, and polio. But the awesome thing is that we have combination vaccines that reduces how many injections you have to get. So in our clinic, at the Trinity Health Clinic where I work, and I think, Melissa, you might be able to speak to whether this is constant throughout all of Trinity Health, we use a vaccine called Vaxelis, which combines the diphtheria, tetanus, pertussis, polio, Haemophilus influenza, and hepatitis B into one vaccine. So you just get 2 injections, and then the rotavirus vaccine is oral. And that's the same at 2 and 4 months. And then at 6 months, you get those same vaccines, plus you're eligible for flu and COVID. So I just like to highlight that we do have ways of making it fewer pokes, even though it looks like a lot of vaccines. So if it's okay, Melissa, I'll go to the next slide, unless you wanted to add anything.
Jen, yeah, we talk about one of the questions that kept coming up that I don't think we have a full slide on, so maybe it's good to talk about here is, can I separate them out? And what happens if I separate them off this schedule?
Yeah, I think Dr. Hollingsworth, Andre, there's a slide in your section, I think, about spacing, but
okay, we'll talk about that then.
Yeah, we can, I touch on it again. Yeah. If you could go to the next slide. All right, so now we're in the 7 years through 18-year part of the schedule. We did receive one question about the adult immunizations, and we're not going to be covering adult immunizations tonight. We're really focusing on the childhood immunization schedule, but that could be another cool Wednesday wellness to potentially do for the adult schedule. I want to highlight here that we always recommend the seasonal flu vaccine for 6 months and older. That's always, you can see that spans across all of childhood. The things that get added as kids get older, so we immunize children against meningitis. So when kids are 11 and 16 years, it's recommended that they get a meningitis vaccine that protects against certain strains of meningitis, A, C, W, and Y. And then you can see there's a different color recommendation for meningitis B. So that's one of those vaccines where it's just recommended for certain groups. And those groups are kids who are going to be living in dormitories, kids going into the military, living in group settings, or any other kind of congregate setting with kids who are in that late adolescent, early adult life phase, because that's where meningitis B tends to be transmitted. Additionally, we have human papillomavirus or HPV vaccine, which is an amazing vaccine that prevents against types of cancer that are caused by the HPV virus. And that we start at 9 years. It's a 2-dose series. You get a booster of your Tdap, because again, that concept of needing to boost the immunity over time to remain having good protection against different illnesses. And then the COVID-19, we're going to talk about COVID-19 recommendations a little bit later, but for this age group, it is the AAP's recommendation is that if you've never had a COVID vaccine, you should get one. If you've had your primary series, an additional COVID vaccine gives you if you had your primary series, meaning you already had COVID vaccine and you're this age group, you have great protection against severe disease. But if you get a booster, you get like 6-ish months of protection against mild disease. And so if that's important because you're high risk, like you have asthma or you have a cardiac issue, or if you live with someone who's high risk, like a newborn infant, or you're visiting with grandma and grandpa a lot who are high risk, that could be a reason that a child might get a COVID vaccine, but it's a shared decision-making framework. It's high risk and then shared decision-making for everyone else. And if parents just want their children to have a COVID vaccine, that is also okay. One of the questions that did come up is about access and insurance coverage in the midst of everything that's been going on. And as of right now, insurers are paying for vaccines according to the AAP schedule. We haven't seen any issues with that, and most of them have committed to following evidence-based recommendations for vaccines.
I would just say about the insurance also, to interject there, Dr. McDonald, is that
Yes.
We are still waiting for supply for what we call our VFC, which is our Medicaid stock for vaccine for everywhere. Because the federal funds were a little held up on getting that for COVID only. So otherwise, I think that will be coming, but that's the only one where there's some insurance staff who is trying to just get the supply, but we think that's coming soon.
Awesome. So I'll go to the next slide. So we received several questions, and this is a common one that I hear in clinic a lot is it really okay to give all of those things at one time? And I really understand this question. Like it looks like a lot. And the answer is that the short answer is that yes, it really is safe to give all the vaccines together according to the schedule. And the reason that we know it's safe is because in order for something to be added to the schedule, it is tested alongside all of the other vaccines. Like, so for example, when they added, let's say the Haemophilus influenza vaccine at 2 months, they tested it with all the other things that also happen at 2 months so that we know that one, we don't see increased risk of severe side effects, and we don't have the vaccines kind of interfering with each other and leading to less immunity. So it definitely is safe to get the vaccines at the same visit. Like I said, there's a slide, I think, later in the presentation. Several people asked about spacing vaccines, and I'll just put a little plug in here that generally it's great to get the vaccines that you're due for at the time you get that you're due for them for multiple reasons, which we'll talk more about later. But one of the reasons is that it means fewer visits. And fewer visits save parents time, saves parents money. I also, as a pediatrician, I like to keep my littlest babies out of clinic in the winter. I don't really want kids to have to come to clinic unless they absolutely have to because they are sick or they need to see us for another reason. To come back for vaccines is potentially exposing kids to things in clinic. We try really hard to keep our clinics very clean, but we're seeing sick kids in clinic. So if you can get your child their vaccines when they're due for them and then come again when they're 4 months for the next ones, that's my preference, just so that we're not exposing children to things in clinic. I think that's what I had for that slide. And then we'll go to this one. This is another really common question, and it came up in the questions that you guys submitted. It's a great question because it's true. The vaccine schedule has changed a lot over time. Children do get more vaccines than they used to get in the past. And I think it's always important to anchor any conversation about how the vaccine schedule is changing by remembering how much suffering there used to be due to vaccine preventable disease. So just, measles used to kill 400 to 500 children a year. Diphtheria, there were 15,000 deaths of children annually in the early 20th century before the diphtheria vaccine. So let's talk about how the schedule has changed. Let's compare 1980, so that's about around the time I was getting my first vaccines to now. And in 1980, the vaccine schedule for children included 7 diseases. It was diphtheria, tetanus, pertussis, polio, measles, mumps, rubella. 7, 7 things. And the reason that we weren't immunizing for all the other things that we do now wasn't because they didn't want to. It's because we knew what diseases were causing problems in children. We just didn't have the science yet to make the vaccine. So the fact that we're able now to protect from, it's actually, here it says 15, but it's actually 18 because that didn't include COVID, flu, and RSV. So our current schedule protects against 18 things. That's a real triumph of science, right? We've identified things that cause illness and death in children, and they've created vaccines that can prevent that. Another really important thing to note, though, in addition to just like science giving us more vaccines, is that the vaccines actually are so much better than they used to be in terms of there's so much less in them. So through new vaccine technologies, they've really been able to reduce the number of antigens in vaccines. So an antigen it's either like when we just get an infection, it's like the part of the virus or the bacteria or the toxin that our body recognizes and forms an immune response to. So antigens are contained in vaccines. That's how it stimulates the immune system. And it used to be with these old vaccines, because of old vaccine technology, that when you got in 1980, if you got all of your vaccines through age 2, you'd get exposed to 3,000 antigens. And those vaccines were still effective and safe. But what's amazing is now we protect against 15. Here, they're just doing 15. So this does not involve flu, COVID, or RSV, which would be like, I think 5 more antigens. But the total number of antigens that you're exposed to now is 180. And it's in just putting that in context on a daily basis when kids are out, playing in the sandbox, eating dirt, just eating food, just being kids, they're exposed to way more antigens on a daily basis just by being alive than they are in their entire vaccine series. So I think those are the questions that related to the slides that I had prepared. So I think now I'm going to hand it over to Dr. Hollingsworth.
Awesome. Thank you so much. And so much great information initially coming out. Let's see, can we go on to the next slide? All right. So they often say a picture's worth 1,000 words. Well, I've got 2 pictures here that are worth way more than 1,000 words here. So these 2 graphs here, one on the left and one on the right here, just show the impact that vaccines and even modern medicine have had with vaccines here over the past, I would say, almost past 70 years here. So the graph on the left here shows the number of cases of vaccine-preventable diseases at a specific time in specific years. And this goes back to about the 1950s. And if you can see, we started in the 1950s about 3.5 million cases of these vaccine-preventable diseases back in the 50s, which is astounding to think about that. And if you look and see dramatically, you can see this line decrease rather quickly over the span of roughly just 35 years into the 80s, where we go from 3.5 million down to under a million deaths, now to the point where now we're just maybe just over thousands of these cases, which is remarkable in the span of, like I said, these years. And what does that tell us? Is this the testament to just modern science? So initially, when we started with vaccines, we only had a few vaccines to begin with and start with. We started with things like vaccines for instance, tetanus, diphtheria, pertussis. These were some of the earliest vaccines that were created. And as we got a little bit smarter, as we were able to use science to progress things, we started developing vaccines against other diseases that were just essentially harming our children and taking people out of this world. And so things like polio, things like hepatitis B, things like chickenpox and varicella, we were able to develop vaccines that were able to prevent those things and decrease cases of that over time. And if you can see over to the right, this graph shows the amount of deaths kind of over time from that same time period, from about the 1950s up until about the 2020s, 2025. And you can see it looks remarkably similar to the graph on the left. And so in cases of deaths, we're talking about decreasing numbers from 50,000 to literally we're talking less than hundreds of deaths per year for now from these vaccine preventable illnesses. And that's, like I said, it's a testament to science. It's a testament to the introduction of vaccines, and just kudos to our pediatricians and those that spread the word about vaccines and getting those out there to the general public. Adopting these vaccines has been one of the greatest public health measures we've ever undertaken. And so these slides and these graphs are just a representation of that. And I'd like to take a minute just to say one thing about, these graphs. There's a lot of talk in the news right now about things about causation and correlation. You'll hear these terms probably a lot here over the next several weeks, months, as headlines start to come out about many different things. And this is one of the things I will say in regards to those things. There aren't many things where I will say definitively, like, we can say things actually cause things. There's a direct cause, and vaccines are a direct cause of preventable these vaccines are a direct cause in the decreased amount of deaths that we're seeing from these vaccine preventable illnesses. And so once again, it's just a testament to modern science, and we're just amazed that as we progress and we learn more knowledge, that we're able to create more of these to help us all along the way. So if we can, let's like to move to the next slide.
Can I make one comment on this too? I thought of another point on this. When I look at this, I also think of what people talk about. Well, if I don't get my vaccines, I'm still okay, because you are, maybe because most of the people are vaccinated, because we have eliminated so much of the disease due to most people all getting their vaccines, and you're protected by the herd around you because the disease burden is so little in our communities sometimes. However, if people start not vaccinating, then the numbers go up, and that protection around you in the community goes up as well. So, that is sometimes the concern that us as pediatricians really face.
And this is a question that was definitely posed and comes up, often. Why do we need to get vaccines for diseases that are mostly gone or mostly eradicated? First and foremost, there's really only one disease that's actually ever been completely eliminated by vaccines, and that's smallpox. Well, unfortunately, although these diseases are mostly gone, they're not absent. And so, as we just discussed, even though the rates may be lower, we may have increased rates of vaccination. The problem becomes that we still need these vaccines to maintain our immunity. Immunity wanes over time. And so the less people that we have immunized, the children that we immunize less, it doesn't allow for the protection and immunity that we need. We talk a lot about herd immunity, and we can't have herd immunity if we don't have people that are immunized. And so it's very important that we continue to immunize, even though the rates of these illnesses may be low. And I'll put another caveat here. The illnesses may be low here in the U.S., but for those that travel or go abroad, it doesn't mean that these illnesses aren't prevalent in other countries and other places. And so having these vaccines here, having your child vaccinated here, also protects you abroad. And so like this picture here, it's kind of like having a dam, right? We build a dam, and then we want this dam to protect us from these diseases. And what vaccines do, they're like our dam. They're like our dam stopper. We put this up, and if we vaccinate and we continue to promote vaccines, what happens? It creates a wall. It prevents it prevents numbers, like we saw on the previous slide, or those graphs. It prevents those numbers from going back up in the opposite direction. Because if you take that dam down, or you decrease your vaccination rates, or you don't continue to vaccinate the way we have and attack these vaccine preventable diseases, and that dam breaks, well, guess what? The floodgates open again, and those numbers start to rise again. And so we have to protect against it. And the only way to do that is to continue to vaccinate. And these vaccines, thing I'll say is we can't predict necessarily which vaccines or which child is going to have a mild illness if they're not vaccinated versus a child that is vaccinated or who gets severely ill from illnesses and die. So we continue to need that protection in regards to vaccines. So we need to be cognizant and aware of that. And it's just about keeping that dam up and keeping those vaccines and those numbers up so that we can prevent those numbers from going backwards instead of keeping those numbers down. So Dr. McDonald talked a little bit about these numbers on her previous slide, and I'll touch a little bit about these. But as you can see, before vaccines, these numbers were incredibly high. For example, with diphtheria, tetanus, and pertussis, back in the 20s, 100 to 200,000 cases per year in the U.S. We had children dying, 13 to 15,000 children dying a year from, once again, a preventable illness. And now, that same time frame in the 40s, we had tetanus, about 600 cases per year, 30% fatality rate, from wounds, pertussis and whooping cough in the 30s and 40s, 200,000 cases annually, 5,000 to 10,000 deaths per year, mostly, like I said, affecting infants. And these numbers are the same for a lot of these vaccine preventable illnesses. So, that's Haemophilus or polio or the pneumococcal conjugate vaccine. What you'll see is these cases were astronomical in number. Deaths were sky high. And now, because of our push for vaccines and having children get vaccinated, we don't really see these deaths as much anymore. And it's, like I said, a testament to modern science and a testament to the vaccines in themselves and what we've been able to do. And so the numbers continue to decline, and that has been an excellent thing. And that goes not only for those vaccines here, but also the bigger vaccines. So things like measles, mumps, and rubella, which get in the news a lot, varicella or chickenpox. These cases were causing so much illness, so much death, so much morbidity and mortality. And the advent of vaccines is just dramatically reduced, and almost in some cases, eliminated diseases that were once again sickening or killing thousands of our children, every year. And so, bottom line, vaccines dramatically reduce these illnesses.
Hi, Dr. Hollingsworth. I just wanted to jump in, particularly about chickenpox vaccine. I feel like that's one that a lot of families, because people, like I remember having chickenpox, a lot of people remember stories of people in their family having chickenpox, and they're like, do we really need to immunize against chickenpox? And I think that's because a lot of chickenpox, like the chickenpox I had, was not severe. However, it's important to remember that it really was causing, because it spread like wildfire through communities. You would see every year like 10,000 hospitalizations, and children would die of chickenpox. And I think that, getting back to that previous slide, when a child is sitting in front of me and you're making decisions about your own child, it's not possible for us to know if your child is the child who would have the mild form, or if your child would be one of the unfortunate cases that would have the more severe form. And so I think that the importance, Paul Offit, he's a infectious disease expert at Children's Hospital of Philadelphia. He always says there's no risk-free choice, because sometimes I think people feel like when they're choosing not to get a vaccine, that's avoiding the risk of the vaccine, but it's taking on the risk of potentially being one of the cases that gets that illness and then potentially having the really severe form. So that's just something I try to work through with my patients, to really think about, like, there is no risk-free choice. And that even though it is true that, people do have mild cases of these diseases, but we know that there is the possibility of having really severe outcomes. And we just really want to help people understand that risk and then eliminate that risk if they can, or at least reduce their risk. Okay, thanks.
I always talk about that too for chickenpox, so I'll just share that as well, because I was a pediatrician before I had kids, and working down in Detroit at Children's Hospital and watching some people with just poor access to care not being able to get vaccines simply. And when you see one case of chickenpox going to the brain and causing a normal, healthy 12-year-old have meningitis and not be able to walk after that from chickenpox, even though that's not most of the cases, you do see that in just a couple of years of your residency. That's enough to really convince you that when I did start to have my own children, that I thought, well, okay, this is more the risk that I lay my head on the pillow at night saying I did the best to protect my kids more than anything.
Another great question that was posed earlier: can those shots be spread out over a longer period of time? And I'll say, no, we don't like the shot spread out over a longer period of time. We've studied these vaccines and the schedules that, they're designed to work at certain ages, and, the intervals between those dosages of what has been routinely, studied. And so stretching out these vaccines or giving vaccines at different periods or different intervals than what's been recommended, we really need the data or the research to really kind of back that up. And aside from that, we like to give these immunizations at the time that they're recommended, simply because that's when the child's most at risk. And so we want to make sure that we're able to get them these vaccines when they're most at risk and when their immune system kind of responds, the best. Also, when it comes to delaying or spreading out shots, in regards to kind of office flow and workflow, usually the way the vaccines work, or we have a flow and we're typically adhering to a schedule, there's just also an increased risk of error, since sometimes you may be giving these shots at different times where your staff or other individuals may not be used to giving things at certain times or different times. And so that routine or giving these things at these protected intervals, or those intervals that we have created, creates less of a risk for error. And so we always trying to decrease the risk of error. So keeping things keeping things along with the standard flow and then the standard standard immunization schedule are what works best. And also, the other thing I'll say with that last point on the slide there, I think is really important. Delaying vaccines means a longer time that a kid just doesn't have protection. And so you want to be able to close those gaps and decrease the time frame or time period where a child just doesn't have protection from those illnesses that we've been discussing. This question. So we know this question would eventually kind of pop up in the from the individuals or anyone, and it's definitely making its way in the news right now and rounds again. And the question is, how do we know the rise in autism isn't due to vaccines? Before we kind of get into that question or delve into that question a little bit, just a little bit about autism in general. And the question is, frankly, we still don't understand what causes autism. We think that there's likely a genetic component and probably some environmental factors, but the fact is we truly don't understand it yet, and we're still researching to find the actual cause behind it. Now, what does that exactly mean, or how does this tie into vaccines and the autism and the question between these? Well, what happened was back in the kind of late 90s or so, there was a small study that falsely claimed there was a link between vaccines and autism. It was put out by a doctor overseas who published it, wound up losing his medical license for just falsifying data. Now, since then, there have been multiple studies involving lots of children, just searching for a connection between the two. And many studies have shown there's no connection between the two. And there's actually been studies that have shown, or taking kids that have received vaccines, kids that haven't received vaccines, and we've looked at the rate of autism between those two groups. And surprisingly or not surprisingly, there hasn't really been any difference between the two groups. And I say that to say, if there were a link between the two, we would really expect that those children that receive vaccines would have a higher rate of autism, but that's not true. according to these studies. So really no connection between the two. Now, another thing that is often blamed or has been blamed in the past is a component of vaccines called thimerosal. And this has been removed from a lot of childhood vaccines over 20 years ago. However, autism rates still continue to rise. And why is that? First of all, like I said, autism is complex. We don't understand it, but we are getting better in terms of diagnosing it and recognizing it. And so a lot of that has to do with just recognizing that. And so rates have kind of increased. But the bottom line essentially is vaccines do not cause autism. There are no more getting vaccines, no more put you at risk for autism than not having vaccines. And so just want to say again, there is really no connection between the two. And so choosing to vaccinate is just, it's ideal to just protect your child from these serious preventable diseases and illnesses that we've been discussing.
This one other thing I wanted to add here is this concept, when I was talking about the ACIP and that importance of that evidence to recommendation framework, where you really look at not just that you have papers that say you see this association or you don't, but you look at the quality, the size, whether there's bias, did they account for all the confounding factors? And I think that is, as we move forward, because I anticipate that we're going to be hearing more about this topic just based on what we've been hearing in the news. And I just think as a critical consumer of information, anytime someone is holding up one study as the reason that you should change something, very rare that decisions are made based on one study. It should really be the contextualized evidence in all the other papers, like what's the strength of that study? How does it fit with all the other papers? And I think Wakefield's paper really didn't, that's the discredited paper, really did not meet standards of like what should be published. And that's why it was ultimately retracted. So just remembering that evidence to recommendation framework that looks at all of the papers and grades them is really, really critical for good decision making.
Okay, so speaking of controversial items, we wanted to make sure we address this because this came up also in the questions. It came up during, if people are not familiar with this, this was during one of the recent Senate hearings that some of the senators were bringing this up. And it has been asked of me several times, I think, by several different people, because the study had to do with something in our own backyard here at Henry Ford, and it got some national attention. So this is an unpublished study, meaning the results were never verified at all. So that's the first thing. And Henry Ford's official stance was, it didn't meet the rigorous scientific standards for publication. So exactly what Dr. McDonald is talking about, there is a huge process that you have to go through. And one of the main processes is a peer review, where people who do not have any vested interest in getting paid or anything, other colleagues that work in the same industry review the data. And it couldn't even get to the peer review to then meet the scientific standards to be submitted for publication. So I don't, people are talking about that it might have been because they were suppressing that. But really, the bottom line is the results could not be validated because when you looked at the data, they could not peer review it or go through that because vaccinated children just had more visits and administrative, and there was lots of flaws in some of that resulting that they could not explain because of the methods that they used to create this data. So that's really the bottom line of this one. Again, I wish it could be more scientifically funded to understand with multiple studies to then look at this again. But at this point, it just didn't have enough data to put it through that process. Hepatitis B. So also in the news a lot. Speaking of other things in the news, I feel like pediatricians have been very, very, very busy. So thank your pediatrician if you've seen them, trying to stay up on everything going on so we can answer all of your questions in real time, not just on this talk, but every day in our offices and making sure that people really stay informed about why we're still recommending things. And one of them comes to play here. as recent as last week in the ACIP meeting is hepatitis B vaccine. Why is the birth dose still important? So a couple of things. This is not just for sexual contact. Hepatitis B can be spread from toothbrushes, sores, razors, changing somebody's diaper, getting blood sores. It is a bloodborne pathogen. So anything like that, when there's anything blood and saliva and all those things mixed, it can be passed. And the big thing is that before, if you go back to Dr. Hollingsworth's slides, right, before hepatitis B, many children had contracted Hep B, and they contracted it from birth. That is the most common way that they contract it, and they're set to have liver cancer by the time they're even 20. It's very, very infectious at birth. Even though some moms may be tested for hepatitis B, they could have had sexual contact after being tested and could still have contracted Hep B and not even realized it, even from monogamous husbands for years at that point. And so that is the real reason that we give the Hep B at the birth dose. If you wait and give it longer and longer, your chance of building that very infectious disease is much higher risk. And that early protection is critical in the first 24 hours because it already starts to set in through the birth canal and through the birthing process. And that's why we give it so immediate. Again, I have that on the right there about before the vaccine, how many kids were affected. How do we know that vaccines are safe? And Dr. McDonald alluded to this a little bit also with the rigorous study and testing. What I really want to kind of highlight here, because we've talked about this a little bit already, but the main thing I want to highlight is the VAERS safety data. Lots of people will ask the question, well, I don't understand. This vaccine was reported in the vaccine, event reporting system, the VAERS, as not being good. Just because a vaccine gets a report one time doesn't mean it's bad, because it has to have multiple reports and then be studied and go through there. Anybody can report something in the VAERS. Just the other day, we were doing a review of what had been in the VAERS, and they had talked about that lightning struck and the child passed away, and they said that was from the vaccine. Literally, that's what it said. And so there's many things, and anybody can submit to there. So just because it's submitted to there doesn't mean it's necessarily causation from a vaccine. So it still has to go through this process, as Dr. McDonald was alluding to, a rigorous process of evaluating that. And so this is really important. But it is also really important that people report these things to the VAERS, and making sure that our government continues to support these reporting processes and full transparency so that we can see when there is an issue with the vaccine and make sure we're keeping things safe. So what about vaccines for this respiratory season? A lot of people have asked about RSV, influenza, and COVID-19. So just as a summary, here's a slide about who is eligible and what the options are. We alluded a little bit, I think, earlier in the talk about the RSV vaccine for babies. This is really a monoclonal antibody. It's a little bit unique in that it's actually giving direct antibodies. So you could call it even an immunization more than even a vaccine, because you just get those antibodies and they start working immediately for RSV. And then it's after October 1st, those will usually be available in most clinics. Now, if you are pregnant and you had the RSV vaccine in pregnancy, that's another question that we had come up from our questions that we got submitted. If you're pregnant and you had the vaccine before 2 weeks in delivery, that one's called Abrivzo. I always pronounce that wrong. So that one, if you got it before the 2 weeks of birth, then your baby could be protected because that will pass the placenta. If you did not get it in pregnancy, you can get it in our clinics, and that will start October 1st, and then it starts protecting against RSV. It does not eliminate RSV. Your baby may still get RSV. It really prevents the hospitalization more than anything and the severe complications we see with all the breathing problems. So that one's also important. Influenza is the flu vaccine. Again, this is not the stomach flu, and I'll talk about that in a minute. COVID-19, as we talked about, the big thing is this one's a moving target with recommendations. But now, as of Friday and the ACIP, it has led to shared decision-making, meaning talk to your doctor and see if it's a good choice for your child. Let's talk about the flu vaccine. I get this question all the time too. Do I really need a flu vaccine? Is that really necessary? I get all the vaccines. I just don't get flu. Well, let's talk about that. So again, based on what we've talked about before with Dr. Hollingsworth, we were protected by that herd immunity, right? By everyone else gets a flu vaccine, which is why if you don't get it, it might be okay. Well, recently, lots of people have decided not to get the flu vaccine coming out of the pandemic, and then there's a lot worse flu cases. And this is a virus that rapidly changes every year. COVID actually changed and then kind of got a little bit more milder. Unlike influenza, this changes every year. And this is the first year I really want to highlight that we have seen more pediatric deaths in the last 10 years in Michigan than we have ever. Pediatric deaths from actually influenza. And most of these people did not have their flu vaccine. We could argue about other complications they had and other things. I have looked at some of that data and it's kind of mixed on that. Either way, you could talk about that from the previous years as well. The data is also mixed on that about who was sick and who wasn't. The fact is the trend in this graph is going in the upswing, and that makes me very nervous for pediatric deaths. So all those 14 did not have their flu vaccine, and that is one of the compounding factors. What about the flu mist? Most of our clinics do not necessarily all carry flu mist, but that is available now, which is something new in the commercial market. You can actually go to this website that'll be in the links here, and you can order flu vaccine on your own to be given at home with you giving it to your own child. So that's very new this season, and people are a little bit confused on that, but that's a true thing. You can do this for ages 2 to 50 years old. A lot of people ask us, well, can we buy it and then come to your office and then can you give it? No, you got to give it yourself. That's part of the rules of this one, just so you know. But it is really interesting. A couple of things about this, right? Yes, it saves you a shot and it could be, it's as effective, but you don't want to give it if you have allergies to eggs, because even though the regular flu vaccine you can have with an egg allergy, the flu mist is a live vaccine. So you don't want to do that if you have an egg allergy because it's a more active egg protein. The inactive or the shot vaccine does not have that. So that's one of the big differences. The second thing is if you've had any sort of wheezing or breathing problems or things like that, you want to be cautious about giving it as well. There's other things about aspirin. You should go to this website and read about it, and they can tell you all the indications about what to do when you're ordering it. We're told once you order it from this company that you order, it will go to your state MICR record, which eventually goes to our system. So I have yet to see that actually happen because of somebody giving it. So we'll see, make sure that we're paying attention about when we gave that as well. Okay, I think that was my last slide. And so we want to get to some questions and answers, but we want to go through a couple of other things here too, just to let you know what's in the slide deck that you'll be getting. Everyone asks me, where do I go for information? Where do we do this on social media? And that's really, on the websites and social media. So we have some trusted resources, and these are directly trusted resources from the American Academy of Pediatrics and what all of us pediatricians use and follow for information and satire and all kinds of things that are actually fact-based, people that are trusted sources. So feel free to look at some of these as well on your own time. And, lastly, this is, I think, what we just want to leave you with. We know the world can feel overwhelming, especially when you're raising kids today. Child safety concern and health worries feel really heavy. Every day, our calling, every single one of us on this call, and, all of us pediatricians across the country even, really your child safety concerns are at top of mind for us. And that's our calling, to keep your children safe, healthy, and happy. Whether it's in a checkup conversations, we're always happy to answer your concerns or questions or just provide you with reassurance. We're here for you and your family always. Every strong, thriving child deserves a team of people who care deeply, even if we don't agree on everything we're talking about. And that includes us having that conversation. So please be open to just at least talking to us about your concerns and really understanding where we're trying to come from to protect and do the best prevention that we can. Okay. I can unshare my screen now and you can get to some of the questions.
Okay, thank you, all three of you. So we have a couple questions under our Q&A. If you have a question you'd like to ask, please feel free to do so. You can enter those at the Q&A feature at the bottom of your screen. There is an option to submit them anonymously. If you'd like to do that, just please be sure you do that before you submit. Okay, so the first question, I think came up during Dr. McDonald's presentation. Have there been any studies that dissect differences in infant immune system of breastfed babies versus formula fed?
Yeah. So I can, and feel free to chime in, other folks. So there's definitely evidence that breastfed babies do have, there's studies that have shown lower risks of GI illness in the first few months of life and ear infections. Those are the ones that I know most concretely. If the question was more, is there evidence of immune system differences in response to vaccines? I think there have been some studies looking at that, like whether there's immune enhancement of the antibody response to vaccines for breastfed infants versus potential immune interference. And I think the data are mixed. It isn't something I've reviewed recently or extensively. So I don't know if anyone else on the call knows more about that, but generally breastfeeding tends to be immune positive, and I'm not aware of any significant like either synergy or negative interactions between breastfeeding and vaccines.
Yeah, I mean, and I think some of the questions come to if the parent had some antibodies like for COVID, would that come through the breast milk and does that help the baby? We do think somewhat, but it depends on how high the levels are at that time. So I think it can be very variable. But yes, there's also some immunity protection and there could be also some antibodies with breastfeeding. It really depends on how much you're breastfeeding, how much antibodies are circulating, and how the immunity is at that time, and even the age of the child. I think really all those things play a factor.
Yeah, and I think another really important part for kind of maternal to child immunity is really getting those vaccines that are recommended during pregnancy, because that placental transfer is huge. So that protection from pertussis in the first, 4 to 6 months of life that you get from transfer of that pertussis antibody during the pregnancy is critical. Same with COVID vaccine and influenza vaccine, because we can't give COVID or flu vaccine to babies until they're 6 months. And so they really rely on that transfer placentally before the baby's born. So getting pregnant women, getting all the vaccines that are recommended is really critical for their babies.
Okay, thank you. And just to be clear, breastfeeding is not a substitute for vaccination for the baby.
No, absolutely not. Yeah, no, you need the vaccines.
Okay.
Yeah, that's a good clarification. Yeah.
All right, I need to say this one slowly. What is the difference between DTaP and Tdap vaccines?
Let me spell it out. It's big D, little TADP, and then little TADP. So Andre, you want to take that one?
Yeah. So as Dr. Heinen just kind of pointed out, the biggest difference is kind of the components and how much of the components are in each vaccine. So when you're talking about like big D, big T, little P, you're thinking of strong components or strong amount or larger amounts of the diphtheria kind of component of things, as well as the tetanus component of things, versus when you kind of switch over to the big T, little D, and little P, the tetanus component of things, it's still big there, but also it's kind of more of a booster dose and not the whopping doses that, I shouldn't say whopping doses, the larger doses that you get as for protection when you're a baby or an infant and, kind of before the age of 7 specifically. But those are the biggest differences between the two. Larger doses when you're younger, smaller doses when you're older for more booster than a full protection.
I would agree with that. You know what I would add too about this, because I think this is an interesting thing to talk about when we talk about the history of vaccines, is that back in the day, there was a lot of talk about the baby dose of the Tdap giving seizures or having fevers and having lots of seizures. And that is true for the original form of the vaccine. That little A before the P is actually super important part of that vaccine, because they changed it from a scientifically, the words are, they changed it from a pertussis form to an acellular pertussis form. And when they changed it, they saw a complete decline of all those side effects, really, of those febrile seizures or any seizures causing in that vaccine. So that is why we talk about that all the time when people ask me that question about why they're not going to get a seizure with that, because that's really what their grandparents remember, really with that vaccine. And that doesn't happen anymore, because if you look back in time, they didn't have that little A in that vaccine. And that's a really important point too, of how science evolves and we learn to make them safer and safer over time.
Okay. The next question, this person is asking for recommendation, what they can say to a family member who believes that there is a greater risk from the COVID vaccine than from COVID itself for a pregnant mother and a newborn baby.
Okay, I could take that one. So, if this was 2020, I might have a different answer than I would say today, right? So in 2020, there was a lot of deaths from COVID, and we saw a lot of childhood complications from MISC and certain things. However, COVID can still really be harmful for especially babies today, in that they can cause a lot of respiratory things. They can cause a lot of long-term COVID effects that can really affect children and their development and other things as far as the respiratory system. Now, when you actually get the vaccine, the COVID vaccine gives you a robust immune response where you do get a higher fever because it's an mRNA vaccine. It is very active vaccine. And so the side effects you see in the vaccine are only for the first few days of that robust response, and then it goes down. If you don't have those side effects in the first few days and your body responds normally, where you have these robust side effects and then you're fine after that, you're not going to really have long-term side effects of the vaccine, but you very well could have them from the disease. So that is one of the important points I think I would make.
Yeah, I would just add on.
You also say anything else to add?
Yeah, I would just add on that, we have really, we have a lot of safety data for the COVID vaccine that, and numerous studies have shown that the risks associated with the vaccine, again, there's no risk-free choice, right? Like you can get fever after COVID vaccine. Very, very rarely, particularly in adolescent boys, there was this signal where there was something called myocarditis, which is inflammation around the heart that we were seeing earlier in the pandemic with the COVID vaccine. But the risk of that was lower than the risk of myocarditis from getting COVID. That's one of the things I always point out, is that when we think about that myocarditis risk or that inflammation of the heart, it tended to be mild and short, like goes away on its own. It doesn't need, there were a few more severe cases, but with getting COVID, the virus, we saw much higher risks of myocarditis. That's in a different subset, but that safety data has been across all age groups, that we really don't see severe safety signals. And we know that babies in that earliest part of life, that's why the AAP's recommendation is different than the ACIP's recommendation. Their recommendation is all babies 6 months through 2 years should have the vaccine. It's a recommendation versus the older kids where it's more of like if you're high risk, or there's kind of a shared decision-making framework. But because those youngest kids are at highest risk of hospitalization and having more severe COVID, the vaccine, the risk-benefit ratio really falls in favor of getting vaccine.
Great.
Yeah. Okay. This next question is, if the parents get all the vaccines for themselves and their child, how at risk will their baby be from other family members who don't get their influenza, Tdap, or COVID boosters, considering they went through the original COVID shot and boosters in 2021?
So I think it depends on the age of the baby. Can the baby have, if the baby's older than 6 months and has their vaccines, I think that the risk, as long as people aren't symptomatic, is pretty low. I think that as we talked about earlier, COVID vaccine was always meant to prevent severe disease. It's not a great vaccine for longstanding protection against mild disease. And so if you've had your core series, you have protection against severe disease. if you don't get seasonal boosters, you're more likely to have breakthrough mild disease. And if you get boosters, you get about 6 months of protection from mild disease. But certainly if it's a baby over 6 months who's had all their immunization, there's still always the risk for some breakthrough infections, but it should make any infections they get less severe. I don't know if you guys have any additional thoughts
I
about
think
that.
the question is actually asking too, if the parents get the vaccines for themselves and their child, will the baby be at risk from being around other family members, not getting vaccinated? And I just think that's hard to say. Every baby, even with the vaccines, you do not have 100% protection.
Mm-hmm.
So sure, your baby's still at risk, right? Even in that setting, that's like a good case scenario, but you will still be, there's never zero risk, even with the vaccine. I think staying around people that aren't sick is a good measure. That's what we talk about. I think especially babies are more at risk under 2 months for getting sicker than over 2 months. Dr. Hollingsworth, did you have anything else to add with that?
No, I agree. I think it's more in line with the age, of the infant and the baby. And, like I said, under 2 months, I think very much an increased risk of, or I should say an elevated risk of contracting some of those illnesses. But in the grand scheme of things, if you're doing all the right things in terms of, getting your immunizations and, washing your hands and doing the things that you normally should be doing in terms of infection kind of prevention, then I think the likelihood is a lot lower. Like you said, not zero, but much better than having no protection at all.
And the other thing I would say too is paying attention to outbreaks. I think that's a really important point when you're talking about particularly these 3 diseases. Do we see outbreaks of them? Absolutely. Where the cases are much, much higher. So if you're around people who are unvaccinated, that's really when I would be really concerned. Flu, you can track that on lots of systems with the Michigan Health Department, all kinds of things where those, hear them in the news when the flu goes up, the COVID goes up, as well as when you're talking about Tdap, that would be mainly the pertussis that we're talking about. And we definitely see outbreaks of that. I mean, every year for all 3 of those at different times that they'll peak. So paying attention to outbreaks is really important too if you have infants or little ones. And I think that risk definitely goes up during those times.
Are there any limitations you should put on spending time? Like if you have maybe someone who is supposed to be a caregiver for your child, but they are not getting any of the vaccinations that, their doctors have recommended, would it be recommended to maybe have someone else care for the child for the first 6 months? Or do you have recommendations around that?
That's right. That was one of the questions actually that we didn't slip into the slides, right? Someone asked about immunizations for caretakers. It looked like, Melissa, you had thoughts, so I'll let you go first.
Go ahead, you're fine.
So, I think that the safest is that people who are going to be interacting with taking care of young babies, that they have had a Tdap so that they have protection against pertussis, that they have all their vaccines up to date, but certainly getting like a seasonal influenza and a seasonal COVID to try to reduce the likelihood that they would bring those infections in and potentially infect the baby. But I also am sympathetic to the fact that sometimes that is the only family member that you have available to take care of your baby. And then I think there are things you can do to try to minimize the risk of infection. So if that person is at all symptomatic or sick, they should not be taking care of the baby that day. If there's no other option, they should be washing their hands, not doing any smooching or putting the passy in their mouth and putting it in the baby's mouth, and wearing a mask. So masks do prevent transmission. And in those contexts, I think that can be really helpful if you don't have another option. I don't know what you guys think.
Yeah, I was just going to add that I think really just making sure too that people aren't sick around them.
Yeah,
that's what you said. Knowing if they have a fever or sniffles or things like that, because it can turn kind of quickly.
Yeah, I always say with my new babies, I say, if your baby's less than 2 months old, or especially if they were premature, if they have other issues, if somebody says, "Oh, it's just my allergies," I'm like, no, just assume if someone's having like a runny nose and red eyes and that it could be infectious. And I try to, unless they're like really sure they always have allergies, it could be something infectious. And that those kids less than 2 months are really vulnerable to severe disease if they get sick. So we try to keep them really healthy.
That's one of my favorite explanations. It's just my allergies as I back away. Dr. Heinen, you mentioned monitoring outbreaks. Do you have a resource for monitoring outbreaks in the state of Michigan or any state, I guess?
Yeah, really. It's the Michigan Department of Community Health website. So you can Google that and it'll come up. And you can even put in Google, outbreaks of, I would really follow those three more so: COVID, pertussis, and influenza during the winter season. However, obviously it'll catch heat in the news when there's, outbreaks of other things that we shouldn't be seeing. Things like measles, which being, a pediatrician for over 20 years, almost 20 years now, I haven't, I've had that twice now recently and didn't have it the first, 15 years of my career. So I think those things are interesting and a little bit scary. So things to kind of pay attention to in the news when there's unusual ones. But during the respiratory season, you can easily find those on the state of Michigan website.
Okay, and it makes me think if you're planning to vacation somewhere with a small baby, that's probably something you can find in other states' websites as well. If they have any outbreaks you should be aware of.
Absolutely. Right. Like Texas that had big measles, that was out there as well. Obviously, we're also a great resource for your pediatrician. If you're not sure, send us a MyChart, send us a message, and we can tell you what's happening. We try to, send out emails and follow up. We have an Instagram page. We have a Facebook pages. We try to keep all these up to try to make sure that we're, connecting with people and getting the right things, or send out emails periodically. It's sometimes hard for us to keep up, but if you haven't seen anything recently, and you can ask us about where you're traveling to. And the other good thing is to know, also, when I think of these things is, we had people traveling to Texas when there was a big outbreak of measles, more recently. And sometimes it's okay to vaccinate, and recommended to vaccinate earlier than 12 months, because people are in an outbreak situation. And so when those kinds of things happen, reaching out to your pediatrician and asking them, do I vaccinate early? And is this a situation where we would be concerned about it? Or I'm going to this location, is that okay? We get those questions all the time. We're happy to answer them too on a case-by-case basis.
Absolutely. And especially international travel. I think people don't always realize that for babies who are older than 6 months, there are implications for vaccines if you're traveling internationally. And that even includes Canada, because Canada's been a site with measles outbreaks. So worth reaching out to your pediatrician at least 2 weeks in advance, because it takes about 2 weeks for the immune system to kick in. So we'd like to see you, in advance of your travel, not the day before, if possible.
Okay, excellent. I think we've answered all of the questions in some way, shape, or form throughout the last hour and 15 minutes or so. I do want to say that the one thing I've learned as a parent is that you have all this information kind of at your fingertips with the internet and friends and family, but nothing replaces just a quick conversation with my pediatrician. I will call and say, hey, I'm just really confused about this. Can I bring my son in? Can we talk together? And it just makes such a big difference to have that face-to-face conversation. So I'm forever grateful for all of you. And I'm so grateful that we have you and many, many other pediatricians who are taking really good care of our communities. So thank you so much for taking the time tonight and for presenting. And we do have one more question. Would you like to answer that one before we jump off? It's about the MMR vaccine being changed. Go ahead. So it's being changed to 4 years, like the MMRV. Is that?
Yeah.
Sorry, I'm not sure. Yeah,
MMR. You want me to take that one? I can take it. So there's MMR, which is just measles, mumps, rubella, and then there is another product on the market called MMRV, where they combined the MMR with varicella to reduce pokes. And if you give the MMRV shot earlier than 4 years of age, like if you use it for the 1 year, because at 1 is usually when you get your first MMR and your first varicella. But some parents choose that they just want one injection. There is a higher risk of febrile seizures with that vaccine. That's a known side effect. And despite that side effect, it is still the benefits of that vaccine outweigh the risk, because it's still a low number, but it is higher than when you do the two separately. And so in the recent ACIP meeting, they discussed this. And that group decided that their new recommendation is that you cannot, or you're not supposed to use the MMRV at 1 year. You can only use it at 4 years. But they're not saying that you shouldn't get the MMR and the varicella separately at 1 year. That's still on the ACIP CDC schedule, that at 1 year you get your first dose of MMR and your varicella. What they did was took away the option for people to get that combo vaccine, which in Trinity Health, we use separate MMR and varicella. That's just the choice that's been made. But there have been other practices that have decided to stock MMRV because parents want just one poke to get the 2 of those and take on the risk of the potential of having a febrile seizure. And that is one difference between the AAP and the ACIP CDC recommendations, is that AAP, similar to multi-dose flu that has thimerosal in it, they're still okay if that is what is available, that's what you could use. So they didn't change the actual schedule. They just changed like when they are kind of, quote, allowing people to give MMRV. I hope that helps.
Yeah, that's a great explanation. Thank you. Okay,
And
so
I love the last comment in here. There's no more questions, just saying thank you. An incredibly difficult time to be a pediatrician. That's really nice. So thanks.
Good.
Yeah, thanks. And it's hard to be a parent right now, so please talk to us if you need
It is.
anything. That's why we're here.
Bye. Yep.
Yeah.